Good evening, everybody, and welcome all of you to the webinar number 100 at Orthopaedic Principles. And today I'm proud to host my very good friend, Manoj Veetil, and also in the Zoom room is my another good friend, Santosh Venkatachalam, with whom I hosted the first live program. Manoj Veetil is currently working as consultant orthopedic surgeon at Sandwell and Birmingham NHS Trust. He completed his post-graduation from Calicut Medical College in India and did his research fellowship and trauma fellowship at Endo Hospital, Coimbatore, along with a microsurgery fellowship. Manoj started working in the UK since 2004. After finishing training, he did fellowships in lower limb arthroplasty and revision hip surgery at Bristol and Southampton. He took a research interest in metal-on-metal bearings and failure methods. His primary area of interest is lower limb arthroplasty, revision arthroplasty, and lower limb trauma surgery. Manoj has an intense academic and research background, and he has developed a unique management pathway for patients presenting with metastatic bone disease. So today he's going to enlighten us about his new care pathway for patients with metastatic bone disease. So today it's my great honor to introduce you to Manoj Veetil from Birmingham, United Kingdom. Over to you, Manoj.
Right. Thank you, Hitesh, for a nice introduction. It's a pleasure to meet you again. So my topic today is about metastatic bone disease. I would say I was telling Hitesh beyond FRCS education. I just want to popularize the management policy for this quite devastating condition. So I have no disclosures to declare. So the format would be, I'm going to talk about the actual condition for a few minutes, then how they are presented and how we can actually work these cases up for planning management, and a few algorithms how we can manage when they're present to an orthopedic department. So bone metastasis generally occur in a very predictable distribution. In order of frequency, spine is the commonest area of involvement. Then you can affect pelvis, ribs, and the proximal limb girdles. It's very uncommon to go beyond the knee or the elbow. It's extremely rare. And if you see a case, you have to always suspect lung primaries. So these are the locations most commonly found. Axial skeleton commonly or more occurs more openly, more frequently, and epidemiological skeleton after that. So epidemiology is the most symptomatic and disabling manifestation of secondary cancer. And currently, the long-term survival has improved gradually due to the improved medical management, I would say. And you can expect metastatic deficits in about 2/3 of the cancer patients. Almost any carcinoma can actually metastasize in bone. So as we all know, the most common primaries are prostate, breast, lung, renal, and thyroid. In female, 80% of the cancer is actually from breast cancer or a lung cancer. In males, it's prostate and lungs. And other cancers, including cancer of unknown primary, constitute other 20% of the metastatic bone disease. So various studies across the world actually demonstrated a lack of sufficient orthopedic input in managing this rather devastating condition. So the biggest challenge for the cancer treating physicians or surgeons are disseminate the knowledge to colleagues and the oncologists to get the orthopedic surgeons involved. So let's briefly mention about the mechanism of pathological fracture. So we all know it's actually the bone is quite weakened by the metastatic involvement. So it's quite significantly different from usual traumatic fractures. So usually the bone dissection will produce a stress riser in the bone, and it is accompanied by a low energy fracture with very minimal soft tissue injury. Most patients will complain of a prodromal pain lasting usually weeks before the actual injury or actual fracture. So the weakened and demineralized bone may give in, and that will lead on to a fracture. Most people are actually comfortable with good analgesia and immobilization with a splint. So that will give you time to investigate and do the staging of this injury. So if you go into the further micro details of how they lead on to fracture and bone destruction. So this is basically transforming growth factor beta. That's the fundamental chemical involved in initiating the bone destruction by activating the osteoclast. So if you can see from this picture, the TGF beta is actually come from the bone matrix. It can stimulate the cancer cells to produce more TGF beta. It will also produce stimulate the cancer cells to produce PTH-related peptide, as a parathyroid hormone-related peptide, which can in turn activate the more osteoclast. This can also stimulate rankle, which is again a osteoclast stimulating chemical. So all these activity lead to more osteoclastic activity and subsequent bone destruction. So let's go to the outcome part. I mean, in general terms, failure to intervene prophylactically, I mean, when you see a lesion and if you don't address it, then you can expect a poor outcome. And the other thing is use of inappropriate surgical implants. People may try to fix a fracture, especially subtrochanteric fracture, and if the patient outlives the implant, then you're more likely to have a patient with a failed implant requiring further surgery when he's actually physically not that well. And the other thing is, as surgeons or as a team of doctors treating a patient, the failure to appreciate the treatment options available, especially in the current situation, we got various advanced modalities of managing any cancer patient. And if you don't discuss with your colleagues and if you don't arrange for a multidisciplinary treatment for this patient, you're more likely to have a poor outcome. So prognosis-wise, they're significantly improved recently, especially those without any organ involvement. And advance in medical treatment, especially with hormonal therapy, bisphosphonates and denosumab, there's a big improvement in long-term survivorship. So in 1970s, any patient presenting with a metastatic bone disease would be lasting about 7 months. Now this has gone to average 2 years. And again, most importantly, inappropriate surgery in the early phase would lead to a failure and subsequent complex revision surgery. In the current scenario, breast cancer patients has got a 52% chance of 1 year survival when they present with MBD, and 26% chance of 3 year survival. That's a very good outcome, I would say. So the presentation, most people complain of pain. That's the most common symptom. And the pain is usually worse at night. And even the research currently not shown why they are worse at night. A lot of theories, and there are chemical mediators involved with this pain production, substance P, prostaglandins, bradykinins, etc. Then the other way of presentation is coming to your accident emergency as a pathological fracture. So in our scenario, you can expect either 3 of these presentations. One is acute admission with a fracture. Second, you can get a referral from the oncology colleague, either oncologist or surgical oncology team. Or sometimes a patient can be referred by your general practitioner as a patient with unexplained, long-standing or weak history of musculoskeletal pain. And rarely the patient can come to you as a pathological fracture, then you detect the primary tumor. That's a very unlikely event, but still it happened to me as well. So most importantly, when you look at the X-rays and when you are in doubt, you have to confirm the diagnosis. So the dilemma is in three issues. It could be either metastatic lesion, or it could be a primary tumor, or it could be an infection. The treatment is entirely different for all these three different conditions. So you need to confirm the diagnosis before you actually decide what you want to do. So as you can see, these are all not life-saving or life-threatening conditions. So you have your time to actually investigate them fully. So obviously, an elderly patient with a history of advanced breast cancer or lung or prostate cancer under the care of oncologists known to them for some time, when they come to you with a fracture, then you know the history, you know what's going on, and you don't need to waste much time to investigate it further. At the same time, you've got a middle-aged patient who's been cured with a known cancer for a long time and coming to you with a new bone lesion. Obviously, they need further workup to find out whether that's the lesion is from the initial primary tumor or is something new. And the third scenario would be you will have a lesion, the patient coming to you with a lesion who had a previous radiation therapy and having another lesion on the same site. So you have to rule out a sarcoma, which is a totally different treatment. So biopsy is important, which is indicated if the primary origin of the tumor is in doubt. And if you suspect a metastatic carcinoma, then the workup is concentrating on the etiology, because you know what the primary is. So you need to confirm it is the same primary. So then you need to work it further for further spread. So for every patient, it's a standard practice. You have to do a routine blood test after completing a full history and examination. So the blood test includes a standard test. Apart from that, I would include a myeloma screen and a full bone profile, an LFT to check the patient's physiological status, and also tumor markers. Then once that has been done, you should arrange for a staging CT, which includes thorax, abdomen, and pelvis, and MRI scan of the affected bone to see the infiltration of the marrow, and isotopes scanning to assess the peripheral skeleton, and you could consider biopsy. So that should be the format or the order of the investigations. Now let's talk about the fracture risk for these patients. So it has been shown that the prophylactic fixation of an impending fracture associated with less complication for the patient, and there'll be less shorter hospital stay as well. The scoring system can be helpful to determine what the risk of the fracture is in any patient. So you have to always consider certain factors before you plan the treatment: the fitness of the patient before surgery, and any other non-surgical options available in this case, and what the patient actually wants. And also, there are conditions where they can respond to non-surgical treatment well. And also, you have to realize the likelihood of fracture probably increases with radiotherapy in the short term. And now, looking at the investigations, plain X-rays are completely unreliable, and they cannot give you the full picture of the bony involvement. So that's the reason for a more detailed radiology investigation. So as a rule of thumb, 50% of the single cortex has been destroyed in any view that carries a significant risk of pathological fracture. And in a pelvis X-ray, if you see lesser trochanter has been avulsed, then that patient is going to have an imminent hip fracture. So they all need immediate treatment, urgent treatment. Then you can also always arrange for high resolution CT to study the bony destruction further. This is a scoring system used maybe almost every orthopedic surgeon heard about a Mirel scoring system. So it's highly sensitive, but the specificity is not that good. So this will give you a maximum score of 12. So score up to 8 will give you a 15% chance of pathological fracture, and score above 9, that means the patient would require prophylactic fixation. So that is the usual thing. Score 9 and above, you fix it. Having said that, any patient with a functional pain, the functional pain means any pain coming during daily activities of living, that automatically put the patient for a prophylactic fixation. And also, most importantly, the cortical distraction is read on any view. You don't need to combine the views, just either AP or lateral view. And you can see from this system, from the scoring system, a little lesion and carries high score, and also any lesion around the greater trochanter carries higher score. So it's important that scoring systems and radiographs should always taken in conjunction with the patient's symptoms. So, and also the surgeon should be aware that surgical treatment is actually usually palliative, except in solitary lesions. Then you may try to resect the lesion, but otherwise it's palliative with various other specialties involved. When the patient complains of no pain, then the surgery is not usually justified. But if you do a surgery, you need to follow up the patient. The possibility of implant failures are quite high if you fix a fracture. And why you have to biopsy a lesion, a solitary lesion? This will always avoid a WOOF procedure, which means you see a lesion, then you plan a treatment, for example, an isolated lesion, renal metastasis, which you can resect. And if you try and fix that lesion with the prophylactic nailing, you're actually contaminating the whole bone, then the option of resection has been lost. Similarly, if you try to do a stabilization or resection without a full biopsy confirming or ruling out a possible sarcoma, for example, chondrosarcoma, if you try to fix it, or if you try to resect it without full margin, then the limb salvage option has been spoiled. That means patient will end up in high amputation. So that's why the biopsy is important. And we will see the situation time and time again. Then always discuss the case in an MDT, including the oncologist, radiotherapy specialist, and physicians as well. And you have to always involve the anesthetic colleagues to discuss the fitness for the surgery. And most importantly, a presumed metastasis may sometimes reveal after biopsy a benign diagnosis, or it could be a different primary tumor, and also sometimes change between the primary disease immunophenotype. All this will actually decide on the type of chemotherapy the patient may require at some point. So the bone biopsies sometimes are done by the radiologist. So it's always image guided, and they use percutaneous instruments. So before they do this, there should be a prior discussion with the surgical team so that inappropriate biopsy tracks can be avoided. And soft tissue lesions or soft tissue extension of a bony lesion may be biopsied under local anesthesia in an outpatient setting. So that will delay the further treatment. So any solitary presumed metastasis should be treated as a resectable primary until there is a proof to the contrary. That's the key thing when you see an isolated lesion. And biopsy should be obtained from any soft tissue mass. That is, you don't need to go for the bone. It should be get from the soft tissue. If no soft tissue is available, then we can go for the axable bone. So basically, if you are taking biopsy from the bone, it should be performed in a mechanically safe area. Like you get a biopsy from the metaphysis rather than diaphysis, which can sometimes give rise to a stress riser, or acetabulum with subtroch fracture, subtroch of the femur, again to avoid stress rising. Now, let's focus on the management side. Now, I will just mention the general principles, and I'll go on to the individual situations. So the non-surgical management, basically there are two options, radiotherapy and chemotherapy. So in terms of on radiotherapy, so sometimes they are useful just as its own or sometimes as an adjuvant setting. So for example, any meds on the scapula or the clavicle, radiotherapy would be sufficient, and you don't need to go and fix those lesions. It can produce effective bone healing and sclerosis, and sometimes prevent pathological fracture, especially in more radiosensitive cancers like lymphomas and myelomas, and sometimes prostate and breast cancer as well. And external beam radiation therapy relieves pain, usually, but not in mechanical pain due to fractures. And only 30% of fractures will unite after radiotherapy. So they can, you can't expect them to unite, or sometimes they can delay the fracture healing. So when do you advise radiotherapy? Post-operative. When you do a post-operative radiotherapy, you need to include all of the operating site and the whole of the bone, especially when you're exposing or using an intramedullary nail. In spinal cord compression, this is usually done after the surgery, decompression and stabilization, and also in patients who are not fit for surgery, to relieve pain, to improve mobilization, and also to improve function. So the medical therapy, apart from the chemotherapy, includes endocrine therapy, especially in breast cancers, bisphosphonate therapy to reduce the effect of the osteoclast. And apart from chemotherapy, you can also use biological agents such as denosumab. This is a human monoclonal antibody that binds to rankle receptor, which prevents or stops the effect of osteoclast. And other options, percutaneous cryoablation, which is safe and effective treatment for very small lesions. So this will give a local tumor control. And high intensity focused ultrasound also shown results, but I haven't got any personal experience with that. So let's focus on the surgical management now. So all the patients who require surgical treatment should have a pre-op assessment. So basically, the things which are assessed are the patient's biological age and how well they can cope with the operation, and their functional ability, their ASA grade, and what the patient wants, whether they want a surgery or they don't want surgery. So a minimum life expectancy for surgery is required. For example, any patient with a lower limb fracture, a minimum of 1 month life expectancy should be there. And upper limb, its general rule is 3 months. So this is a very interesting study group from Scandinavia. They came out with this table. So basically, it looks at the patient's metastatic involvement, both skeletal and visceral, and the type of cancer, and also Karnofsky score. This is a score basically looking at the patient's ability to perform their routine task. Any patient with the cancer, the ability to do their routine task. So the score starts from 0 to 100. So above 70 is that's a cutoff to come into this staging. So in this scoring system. So you can see it clearly. Anybody with a score of 0 means they are going to survive longer because they've got a single metastatic lesion. They have no visceral mets. It's actually from non-primary with a better prognosis, and they can do all their normal things by themselves. So that's a score of 0. And up to 1, they said the patient will be surviving more than 12 months. Then score 2 or 3, the moment you go to 2 or 3, that means the lesions could be multiple, and there could be visceral mets. That means it's spread further. And the primary is not the non-usual primaries. It could be something more malignant, and the patient cannot do their normal stuff. They're physiologically much worse off. That means the score is 2 or 3. Anybody with a score 4, which means they are quite weak patients, they are going to chance of survival is less than 70%. They may die in 3 months' time. Okay, so this is Karnofsky performance status. As I told you earlier, it's a standard way of measuring the ability of cancer patients to perform ordinary tasks. So the next thing is patient optimization. So they need to be assessed medically. They need to be seen by nutritional support, nutritionists to check their requirement. And we all know the bone marrow function would be suboptimal due to 2 reasons. One is the previous radiochemotherapy, and the second one due to the bone marrow involvement from the actual disease. So there'll be platelet dysfunction that can lead on to inappropriate bleeding. So there should be a proper clotting assessment. Then fluid electrolytes imbalance should be corrected. Hypercalcemia is a very common scenario in metastatic bone disease that has to be addressed before the operation. Prompt anesthetic review. And certain cancers like renal, thyroid, liver, they tend to bleed. Whether you try to nail them or you try to excise the tumor, there will be massive bleeding. So it's always a good practice to speak to your radiology colleague and consider an angiogram and embolize, ideally within 48 hours. Then these patients are actually prone for increased risk of VTE. That is in spite of their clotting abnormalities. So that has to be always looked at before the surgery and has to be planned in a good way. So they should be given enough VTE prophylaxis. And the most important thing is the level of analgesia they require, because most people would have been on high dose opiate before the surgery or for a long term. So they may have some kind of tolerance. So then you need to really adjust the dosage. So the surgical options for these patients are to support the bone or to replace the bone. To support the bone, we can use the various methods we commonly use for any traumatic fractures. You can use nails or plates and screws, but the only thing is you cannot use a bone graft here. The bone graft's never going to work. But you can augment the defect with a bone cement, which is going to strengthen the bone. In certain situations, especially in subtrochanteric lesions or fractures, the studies have shown replacing with an endoprosthetic replacement is much better outcome than trying fixing them. So implant failure and periprosthetic fracture account for a significant proportion of complication requiring further operation in rather failed patients. And during the surgery, you have to confirm the histology again. So these are the important, this is an important slide where you have to answer these questions. So you have to look at all this by yourself before you plan the fixation. What is the bone stock? Bone stock of the patient. And does it have any mechanical integrity, if the bone is generally weak or not? And the implant you're going to use, is it going to share the load? And is the fracture going to recover with the treatment? And if inadequate, can we augment it? And the constructors are going to be rigid for the patient to weight bear, because you can't leave the patient non-weight bearing. They have to weight bear. And are they going to last a lifetime? So if you talk about the internal fixation, it's got a high failure rate, and that is well documented. And the implant is going to be a load-bearing implant. And you can always consider periortical and locking plates to cover the whole bone, and always fill the defects with bone cement to add extra strength. And most patients get a post-operative radiotherapy, which will reduce recurrence rates following interlation procedures. The role of EPR. So this is considered when there is destruction of the bone around the metaphyseal regions, especially in the femur. So it's highly efficient in maintaining the function with a very low reoperation rate, but the downside is significant cost implications. But at the same time, this should be balanced against savings to the wider health community in caring for these patients. So any role for amputation? Yes. In a fungating lesion, that's the only choice. And when the neurovascular involvement with the tumor, then yes, I would go for an amputation. And it can provide a reliable pain relief in patients with significant pain. At the same time, there's a risk of postoperative phantom pain in a patient who had a long-standing pain due to the tumor. So that has to be taken aboard before you consider the amputation. So patients should be well informed about this. So let's go talk about the proximal femur. That's one of the most common involved area in the appendicular skeleton. So 1/3 of the metastatic bone disease involves proximal femur. They always carry a high Mirel score. Then the surgical procedure, whether you replace or you fix it, that should allow immediate weight bearing. So on the proximal femur, let's talk about the femoral head and neck. So this is one of the commonest sites, and the options here are you can do cementohemiarthroplasty or THR with the long stem if there's any further mets further down the femur to bypass those lesions. And around the trochanter, studies have shown the better option would be a replacement of the proximal femur. But if you've got a patient who's got a poor outcome with less than 6 months of survival, with good bone stock, you can always consider fixing it with cement augmentation. And subtrochanteric fracture, same thing goes here as well. An EPR does a much better job than trying to fix it. And I've seen patients coming back with failed fixation and they've been converted to an EPR. But considering the frailty of the patient, they have a high risk of death on the table with these sort of conversions. Then you can have a situation where the patient comes with a match around the existing implant, and for example, around a THR stem. Then the options are either to remove that and do a full-on revision, or stabilize them with a plate and augment with cement. If you are doing revision, the option would be to go for an EPR, but if the lesion is somewhere in the mid-diaphysis, the better option would be to plate it, then consider an EPR. There's no role for bone grafting at all, and cement can be used appropriately, and it's a very useful tool. Then, as you can see, the durability and lower reoperation rates with an EPR compared to osteosynthesis. Diaphysis of long bones, IM nailing is the better option, and the patient would require radiation to the entire bone and the operating field after the procedure. Because when you do the nail, you're going to spread the lesion further distally. And the implant is going to bear the load. So solid nails are ideal, and you have to go for the maximum nail diameter. You can always use cement for augmenting it. So I'm repeating a few things here all the time, mainly to highlight those points, like EPR for proximal femur lesions, cement augmentation, and the implant has to outlive the patient. Around knee and ankle, distal femur and proximal tibial periarticular lesions. The first choice would be fixation with cement augmented site-specific locking plates. And you can go for distal femur replacement in selected cases, but I wouldn't recommend doing an EPR on the proximal tibia because of the functional consequences following the operation. Try and preserve the tibia, the proximal tibia, especially the tibial tuberosity, for a good function of the quadriceps. And distal tibia metaphysis is another difficult area to treat. Most patients would be managed in a plaster cast or a boot plus radiotherapy, and rarely you could consider cement augmentation with a periarticular plate fixation. and in a very bad, severe bone loss, amputation is the better option. Upper limb, for scapula and clavicle, radiotherapy would suffice, and all the long bones, humerus and radius ulna, could consider nailing or using a long plate. The humerus, the lesions around the elbow and around the shoulder joint, an option of EPR can be considered. That is functionally better. Outcome following surgeries, implant failures for internal fixation are higher than for EPR. That's well documented in the literature. And also patient survival does not appear to be lower after joint replacement than any other surgical treatment. They are comparable whether you replace to an EPR or you fix it. Now let's talk to the acetabulum, pelvis acetabulum involvement. That's another important area which can be quite troublesome for the patient. Pelvis is a common site after spine, and it can be sometimes involved in its entirety. The acetabular involvement has got direct and far-reaching implications due to the patient mobility and their quality of life is completely challenged. Their independence due to central role in weight bearing and mobility. So the pelvic disease not involving the acetabulum can be treated by radiotherapy alone, but you have to be aware of the possibility of radiation necrosis of femoral head and subsequent treatment later on. And small lesions of the acetabulum can be treated by percutaneous cementoplasty to relieve the pain and support the bone. And the significant concern is the gradual progression of the disease with a fracture resulting in painful and undignified end to life. That's why these lesions should be picked up early and managed early. So the principles, debulking as much tumor as possible and filling or structurally bypassing the defect created by tumor by transferring the weight proximally to the intact ilium or sacrum, and creating a durable joint reconstruction upon which the patient can actually fully weight bear. And from the surgical point, we have to be aware of the significant amount of bleeding intraoperatively. So you have to be prepared for that. So the acetabular lesions are classified. There are many classifications. This is one classification I've used. There are mainly 4 groups by Harrington. So in class 1, the lesion is actually on the floor of the acetabulum. The other parts are actually intact. It's a small lesion. And in some situations, people curate that out, and you can fill that gap with the bone cement and do a standard cemented THR. You can use a bony metal mesh and cement and put the cemented cup on top of it. That will stop the further protrusion of the cemented cup. In class 2, there will be deficient medial wall where you need to, if you don't support the medial wall with a cage or some kind of supportive device, if you just put simple cement, they can gradually migrate more medially and can fail. And class 3, the walls, the columns of the acetabulum is actually involved, both anterior and posterior. So they will need further support. So one method which is described is modified Harrington method, where we pass 3 threaded pins from proximal to distal towards the acetabulum, one going into the ischium, one to the pubis, and one into the ilium. And they support the cement mantle which you apply, and then you can actually do a standard THR on this. And the class 4, this is usually where you have to resect the lesion and there's a big bone void which has to be reconstructed. I'll show you some x-rays. So this is a modified Harrington procedure where you could see the threaded pins coming into the ilium, ischium, and pubis, and the cement is applied onto these pins. They act as a solid strut, and the THR can be performed on this. And this is where you have to resect the lesion, either in a solitary lesion or rarely in primary tumor chondrosarcoma, you resect the ileum, and this is called an ice cream cone reconstruction of pelvis. So pelvic metastasis can be silent to start with. So as surgeons, we should be aware of the lesions around the hip and pelvis when the patient complains of minor symptoms, because delay in diagnosis can make these lesions quite inoperable. So let's talk about spine lesions now. Spine is the commonest area for metastatic bone disease, and not all spine lesions are symptomatic. And pain from the expanding tumor tissue or a fracture can be quite disabling for the patient. Sometimes weakness, complete weakness, can be a presenting feature. So if they're not treated on time, high levels of dependency for the patient with high human and financial costs. So in a normal situation, they can present in 3 modes. Sometimes they come to the clinic or go to the general practitioner as simple back pain in isolation with a previous history of cancer or not. And sometimes they come to the casualty with an incipient neurological compromise, and sometimes sudden onset of complete paralysis. In every case, the investigation of choice of suspected spinal mets is the whole spine MRI, not the affected area. The role of steroids in spinal mets. A recent study, Cochrane review, revealed they compared the high dose versus moderate dose with a placebo and showed no big benefits whether you give high dose or a placebo. And also serious adverse effects have been reported with high dose steroids, including upper GI bleed. And current thinking is we could start the patient on steroids if they've got deteriorating neurological symptoms, then which may delay the symptoms where we can buy time for your surgical intervention. So spine mets are generally gradual in, if they're gradual in onset and within hours becoming complete, then yes, you have to consider surgery to expect some improvement and also to stabilize the spine. But if they're rapid in onset and complete deficit immediately and more than 24 hours duration, and the possible recovery is very low, but you still have to operate to stabilize the spine. So despite complete paralysis, the presence of mechanical pain would warrant surgical stabilization. In some selected cases, a single fraction of radiotherapy can be effective just to control the pain in patients who are paralyzed. So let's look at the radiotherapy indications. The patient should not have any instability. The tumor should be radiosensitive, and patient should have a stable or slowly progressive neurology. Disease should be multi-level. Surgery precluded by general condition of the patient, example in multi-level disease with a low survival possibility, with a low prognosis, poor prognosis. And it can be given as a adjuvant treatment for the surgery, and also patient presented 24 hours after the cord compression. So when would you consider surgery on these patients? Any form of instability on spine with a fracture, a progressive deformity, or patient coming with a neurological deficit. And clinically significant neurological compression. And there are tumors which are insensitive to radiotherapy, chemotherapy, or any other medical management. And some patients who developed spinal cord tolerance after prior radiotherapy. Then intractable pain, which is unresponsive to non-operative measures. Then a big tumor encircling the cord, where in all these conditions, surgery is an option, which is indicated. So in summary, in spinal metastasis, prevention of further neurological deficit, that's the one indication or one we all have to be aware of. Then, and also recovery is rare, but it can occur. And the main thing is to stabilize the spine, which is going to allow to mobilize the patient better. So I will talk about the some algorithms which is I found very handy on a day-to-day practice. So, for example, you got a patient who's got a non-malignancy under the care of oncologist and various other surgeons. Has got a non-metastatic disease, and the patient is coming to you with a tumor, and the MDT agrees this is keeping him with the primary diagnosis. Then I wouldn't waste any time on treating this patient. Just treat straight away with whatever is the best modality depending on the prognosis. The second category, you got a patient who's over the age of 40, which is the usual age group for metastatic bone disease, and has got no history of previous malignancy. So, but the X-rays are the initial images showing pictures more towards a metastatic disease. Then that's the time I do all these workup. Get the myeloma screen, your bone tumors, then X-ray of the whole bone, involved affected bone, then always do a CTAP, which is CT of the thorax, abdomen, and pelvis, looking for further distance spread, which is always very useful. And that tool will actually tell you the prognosis and the long-term survivability of the patient. So once you've done these set of tests, if that's showing a clear diagnosis of carcinoma with multiple bone mets, then we know what you want to do next. Then you discuss that and you plan the treatment straight away. But these tests are actually not showing any other lesion than that's the only lesion. Then you have to do an MRI scan of the bone to see the bone marrow infiltration. And then you are suspecting either this could be a single mets or this could be a primary bone tumor. And if you diagnose a carcinoma with a single lesion, again, you get an MR scan, then plan resection and further treatment. And again, if you suspect a sarcoma with a metastasis, again, you have to get an MRI scan and plan resection, because sarcomas are generally not radiosensitive. So you need to plan resection for them. So when you have a patient who's actually under the age of 40, when they're under the age of 40, it's less likely to be metastatic. Again, no previous history of malignancy. You do the all tests, but you also do an MRI scan of the bone because you're suspecting a primary bone tumor here. Then if the image is not typical of a sarcoma from the MRI scan, then you go for the CT, chest, thorax, abdomen, pelvis. Then if that confirms METs, then you take the algorithm same as anybody over the age of 40. Then if no primary identified on the CTAP, then again, you're going back to the same situation where you plan resection and further treatment. So this is the other situation where we find commonly patient coming to our clinic, previous history of malignancy, but not known to have metastatics before. So first time metastatic disease. So again, that means you have to restage this patient here, because initially when they treated the patient for malignancy, the staging was different. Here, there's a distal spread. That means the patient has gone to the last grade of the staging. You have to do all the tests again to restage it. And when you see multiple METs, yes, the same protocol as before. You can plan the treatment based on the prognosis or the survivability. But if you see multiple METs but not keeping with the primary tumor, then you have to do further workup to find out what is a lesion this time. If it's only a single lesion, yes, MRI scan, plan resection and reconstruction if possible. And again, low volume metastasis with good prognosis and long disease-free interval, then again do an MR scan. And when you're doing an MR scan, you're essentially planning for resection or amputation in certain tumors. So in summary, orthopedic treatment should be part of a multidisciplinary approach to management of metastatic bone disease. And a longer life expectancy requires a more durable reconstruction. Fractures caused by MBD may not unite, especially if given radiotherapy. Surgical treatment should take account of this fact. which is replacing the bone rather than attempting fixation. Reconstructions, whether spinal or appendicular, should allow immediate weight bearing and aim to last the lifetime of the patient. A primary bone tumor should always be excluded, and treatment should, where possible, be appropriate for the stage of disease and general condition of the patient, and should reflect the patient's preferences for treatment. That's very important as far as the patient is concerned. So the patient assessment is the key, and if overestimate prognosis, patient may die before any benefit from surgery, high risk of in-hospital complications and death. But if you underestimate the prognosis, implant will fail before patient dies, the social and human cost of revision surgery. So basically, implant must outlive the patient, and patient should have only one operation, and that should maximize the function. So you get poor outcomes. I put this slide as a last slide just to keep, people actually remember the last slide most of the time. So you get poor outcome when failure to intervene prophylactically where appropriate, the use of inappropriate surgical implants which rely on fracture union and for long-term durability, and failure to appreciate the treatment options available as the multi-MDT approach, particularly in more advanced case of MBD, when appropriate opinions are often not obtained, whether to operate or do non-operative management. So minimum standards of care, all patients with MBD should have access to an expert orthopedic opinion and a multidisciplinary care. Opinions for treatment should be discussed with the patient's oncologist in every cases. And follow-up after surgical management of metastatic bone disease should include evaluation of fracture union, local disease progression, and impending or actual failure of the reconstruction. And thank you.
Thank you, Manoj, for that fantastic presentation. You've done a lot of work on metastatic bone disease, so it's pretty easy for you to convey the message. Thank you once again for joining us. But before it's been a long lecture, but we need a lot of questions that we need to discuss in detail. And let me ask you for one or two questions to begin with. One is regarding the seed soil theorem. That's the original description, isn't it?
Yes.
How the cells get off from the primary location and gets deposited. So that's called the seed. Just for the benefit of the FRCS trainees who are there online, and it was described by Stephen Paget. Am I right?
Yes. So I omitted that slide. I actually prepared it and immediately I took it off, just because there are different theories regarding how they spread. So the basic thing is that the cancer cells invades the membrane, the basement membrane, then that's how they spread. And but the key thing is how the chemical mediators actually stimulate the osteoclasts and how they allow them to destroy the bone locally. So I read few research papers on this seed soil theory. Then I thought probably I wouldn't include that in this talk.
And I think it was described long ago, 1895.
Yes.
1895, I'm right.
Yes. So the picture I showed on the slide I showed in this talk was mainly from one of the research group. They were looking at how these things are spread.
Okay. The other one is regarding the Eastern Cooperative Oncology Group score, ECOG.
Yeah.
So how do we use a ECOG score with respect to treating metastatic disease? So
again, there are different scoring systems for treating metastasis. I took the Mirel score purely because that's going to give a kind of prognosis that's easy for people to understand, and for the FRCS level, maybe that's what you need. So basically, you want to decide whether you want to prophylactically fix it or not. Then the other one, the sarcoma, Scandinavian sarcoma, only to give an idea about what the long-term prognosis would be. I explored all the other scores just to stop people getting confused on the scoring system.
So for the FRCS exam, I think Mirrors is more than enough, isn't it?
Yes, yes. And again,
Okay.
for day-to-day practice, I found Mirels more than enough, but you can't rely on Mirel completely. But when you have a patient who's complaining of constant pain, where even the score is 8 or below, I would still stabilize the fracture.
And the ECOG, I think it's more for a response to chemotherapy and the survival, isn't it?
Yes. So I don't use that scores routinely. That's why I haven't gone into that in detail.
No issues. Okay, we have Santosh within our Zoom room, and he was one of the first speakers with us. Santosh, you can pose your questions to Dr. Manoj.
Hi, Manoj. Fantastic
Hi.
presentation. Really nice and very concise. I had a couple of questions. One is the lytic lesion in the mid shaft of a femur, when they come in with a lesion like that, and the primary is, let's say, breast, and the prognosis is 3 to 5 years or whatever.
Yeah.
Now, in that, we know that nailing that fracture is not going to heal, and the implant will eventually fail. How do you tackle those kind of secondaries that come with reasonably good prognosis?
Yeah. So, as you said before, you're staging further CTs for CT thorax abdominal. They're not showing any other lesions, and in a mid-shaft lesion, if the lesion is very small, you nail it, then you give a radiotherapy, and that may kill off the spreading tumor. But having said that, there's no guarantee that that's going to heal completely. There's 30 to 40% chance that it may heal. So yeah, you need to continue monitoring this patient. If the fixation fails, then yes, you have to revise that. But nailing would be still the option.
Yeah.
So I wouldn't try and resect that completely. You can curate the lesion, you can put bone cement if you want to, but I wouldn't resect it, no.
And at what stage is it the lower 1/3?
Santosh, if I can intervene for a second. Manoj, can you stop sharing your screen, because I think your email is coming up.
Oh, sorry.
That's going to be public. I don't want that to happen.
Yeah.
Yeah, great.
Okay, that's right, yeah.
Yeah, okay, Santosh.
Yeah, sorry. So at what level would you consider a distal femoral replacement? Is it below the lower 1/3, would you say? Or
it's usually the condyles.
Yeah.
But the distal femur replacement is actually a much more complex procedure than the proximal femur. The proximal femur is usually a hemiarthroplasty. You don't replace both sides. So if you're usually it's a hemiarthroplasty. So that's why that people are preferring that over the nailing, and also nailing as a risk of failure. But when you come down to the knee, if you are considering an EPR, then you're replacing the tibial side as well. That is much more complex and bigger operation. So now the thinking is, if the condyles are not destroyed, they're intact, you can try and fix it with a long plate, locking plate with cement augmentation. Yeah.
Okay. Yeah. And is there a cutoff at which stage you say with this prognosis, I wouldn't really intervene? Like you said, if it's less than 3 months in spine, is that the same for upper and lower limb extremities, or?
So it says 1 month in appendicular skeleton. So if the patient has got 1 month survivability, then you try and operate on them and let them keep going.
Oh, okay. Right.
Yeah.
Yeah.
So I think in our day-to-day practice, the main case you would see would be a subtrochanteric, pertrochanteric, or acetabular lesions.
Yeah.
So these are the main problem areas.
Yeah. No, it was fantastic. It was a very concise presentation of the whole, because I remember for the exams, I'd looked through the BOOS and BOA joint guidelines, and that was pretty much what your entire presentation mirrored the whole thing. And
I did my fellowship with the guy who actually wrote the guidelines.
Yeah.
So I did see a lot of cases with him as well. So there's a kind of experience from their side, what they would do for a patient like this.
Yeah. No, that was very useful. Thank you. Thanks, Manoj.
Manoj,
Yeah.
quick question.
Yeah.
How often do you do a PET scan, the PET scan for your patients?
No, we don't do that routinely here. I would say it's done for primary tumors or in certain conditions where the routine test actually not showing anything, then go for the PET scan. And sometimes recurrent cases, yes, go for the PET scan. But I don't know, I don't work in the tumor center nowadays. So yeah.
The reason I asked is I work closely with a cancer research center in in Malabar.
Yeah.
One of the first things they do is after your
It's very sensitive. That's why it's very, very sensitive. They pick up straight away.
Yeah, so I mean, I know the cost is the concern and getting it. I mean, how difficult is to get a date for a PET scan in the UK? Is it easy?
It depends on where you are. In a cancer center, they've got to separate funding, and they get it done quickly. And if you do it in other places, then it may take time. But it's not a big deal. You can get it done. Yeah. Maybe 2 or 3 days. That's it. Yeah.
I think there are no more any more questions from Santosh.
No, as I said, thanks again for the brilliant presentation, Manoj.
Okay, thank you, Manoj. It has been a great experience to be with
Thank you.
And I remember the journey that we had 25 years ago when you were a postgraduate and I was a MBBS student.
Right. Yeah. I remember that.
Thank you once again.
It's a pleasure, Isesh.
Pleasure.
Nice talking to you.
Thank you, Santosh, very much.
Thank you.
Bye.
Bye.
Bye.